Hi all, Professor Leah Elliott here. We are going to be doing chapters 1 and 2 in a single lecture, and that is perspectives of maternal and child health care and caring for women. I've combined those two chapters. This is from the current fourth edition of our textbook, and we are going to also spend a little bit of time looking at some evidence-based practice and a few other things that I have thrown in. So the lecture will be about 45 minutes or so. You may have to come back and do it in two sessions, or you can do it at double time. Thanks for coming along on this journey. So here we are. Here are the chapters that we're going to be covering in this lecture. And here's the textbook. It is the fourth edition of our Maternity and Pediatric Nursing. We use this in our nursing program. Here are the objectives. Now, this is specific to my live class, but these are really what we're hoping to accomplish by the end of this lecture. So take a moment and pause this video and just take a look at what it is that we're hoping to get out of this. As we go through the next few minutes, I want you just to kind of sit back and hear the story of childbirth in the United States. It's been, there's a lot of history here, and we're going to look at where we've been. We're going to look at where we are now, and a little bit of where we're going, hopefully, and maybe that will involve all of you. So if you look at the history of midwifery, if you look at midwifery and childbirth, you can't take the midwife out of that. So originally women were always attended by other women. So these are pictures from antiquity, and you can see that they depict women in an upright position being attended to by other women. Now, the other part that came along with this is a lot of women died during childbirth. There was infection, and of course, no antibiotics to treat that infection. So it was a very fearful time for a lot of women. And as we continue on into our more modern day, late 1800s, early 1900s, colonial women were actually terrified of childbirth because there wasn't a lot of support and help, and that fear of going in, when I say there wasn't a lot of support and help, like there was nothing we could do about it when things went wrong or if someone got an infection and that sort of thing. We had lots of help by women that were traditionally trained by other women, and there's a whole lot of history there that is beyond the scope of this course, but it is interesting if you want to get in and look at some of the Salem witch trials and what there were, the midwives of the community and how they were thought of. So they feared death of the newborn. Lots of babies didn't make it at this point. And then, of course, death in childbirth, like I said, was common. So as we continue on through this part of our history, we see that male physicians, because being a physician was not really open to a woman at that point, male physicians started looking at this and kind of moving into this traditionally thought of as a women-centered area. So as they did that, we see the birth of the physician-oriented delivery, and medical schools started really pushing doctors to go into caring for women. And one of the ways they were able to do that was to convince women that it would be safer if you had a physician in attendance versus a midwife. So interesting little podcast here, looking at hand washing and germ theory and Dr. Semmelweis and how they discovered that women actually had a higher chance of getting an infection after delivery if they were attended by a physician. And when they really started digging down and looking at it, it was because they would go and take care of their sick patients in the hospital wards, even cadavers, and then they would come and take care of women without washing their hands. And so just an interesting little podcast. And I'm going to throw lots of interesting little tidbits in here. They're not required for my students, but if you're interested in learning more about it, I've given you the resources. So continuing on, in the 19th century, we saw lots of immigration that led to increased infection disease and several epidemics. Children were viewed as a commodity. You had as many children as you could so that they could help support the family, working on the farm, taking care of the other children. It's just the way it was. In the second half of that century, we started seeing advent of safety measures like safe milk supply and vaccination programs to help rid ourselves of some of these issues. We have a whole rich history of our what they called granny midwives, which was in the early 1900s, following the war. As that shift to physician assisted birth happened, it really was for women that could afford the care versus women, all women. So women that were poor or lived in not as populated areas, they would go to their traditional midwives. And these granny midwives took care of a large portion of the women, specifically in the South. And they had traditions that they passed on from one midwife to another, and they took care of a whole generation of people. And it kind of became a stigma. If you had the means, you would hire a physician to care for you. But if you had not the means, then you would have the local midwife taking care of you. Frontier midwifery was started in Kentucky, rural Kentucky, and this was really one of the first public health initiatives. These frontier midwives would go up into the hills on horseback, as you see here, and care for the women that were in remote locations. They would care for the whole family, actually. So this is what we thought of as our first community health nursing. And of course, babies are going to come along in that part. There's a very rich history with the Frontier Midwifery School, still open today. And if you want more information, again, that's beyond the scope of this course, but it is definitely an interesting ride down our rich history. So in 1900 or so, less than 5% of women gave birth in hospitals. Hospitals were thought of as where you go when you're ill, not where you go when you're having a normal process such as giving birth. By about 1935, 37% of births occurred in hospitals. And how did we make that huge jump? Well, part of it was physicians coming back from the war, and there had been a lot of physicians trained during the war, and they needed something to do when they came back. So, of course, babies are always happening, and a lot of them turned to that as a specialty. And then there was this stigma that I mentioned already about if you can afford it, you have a physician versus having a midwife. And then there was a campaign to get women to come to the hospital. And the way they did that was they told them it was safer and cleaner and they'll have better outcomes. And then they started billing this painless childbirth idea, which I'm going to talk more about in a minute. And it convinced women that that's where we needed to move birth. So by 1950, we had about 88% of our deliveries occurred in hospital. We had completely made that shift. Interestingly enough, that is not the way in other countries. The rest of the country, lots of other countries with some amazing birth statistics still have a majority of the women having their babies outside of the hospital versus inside the hospital. And we'll cover more of that in just a minute as we continue on. So Twilight sleep was this painless birth idea. And these are some actual advertisements. Mothers that passed through twilight sleep and their babies posed for the evening world. And so these women talked about how they had a painless childbirth and it was the most amazing experience. And this really fueled the fire of bringing birth out of the home environment into the hospital environment. But interestingly enough, what these women were actually experiencing was amnesia, because twilight sleep is a combination of scopolamine and some very strong pain medications that basically knock you out and you wake up 3 days later and don't remember the experience. There have been in the recent years some videos and not videos, but photos that have come up about how these women were actually treated. And if you have read any accounts of the nurses taking care of these women, this is what it actually looked like. So these are women under scopolamine. Of course, fathers were not allowed in the delivery rooms at that point. This was a very male-centered hierarchy. So physicians were men, nurses were women, and it was a very hush-hush thing. But these are women, actual pictures of women that were under twilight sleep. It gets worse, by the way. And some of these photos are probably not appropriate for children. So if you have children watching, you probably want to pause this and head them on into something else right now. This is what it looked like for a delivery table. These are stirrups that they strapped these women's legs to and had cranks that would hold them up and open. This is the traditional lithotomy position. This is what it looked like when they were in those stirrups and covered up. You see here that she's in restraints, and that's because when you're under the influence of scopolamine and some of the other drug combinations that they used, they were out of their minds. So they thought it was painless because they had no memory of it, but they were actually out of their minds. This is what the delivery room looked like. It was a very sterile environment. This woman is looking over here at this baby that she has, quote, just been delivered of. We do not do this anymore, where we hold children up. They used to think that that would help clear their membranes of the fluid, but just these pictures just have such a barbaric feeling to them. I wanted to share them with you so you can see where we've been. So as the 20th century, as we moved through, we had safer cities. Again, we had the advent of antibiotics. We had a decreased threat of childhood disease because of our vaccine programs. And just as a little side note, those vaccine programs were made mandatory, and that's how we eradicated those diseases that were ravaging our children, like polio and measles and whooping cough. So our reason for cause of death for children under 1 year of age turned into unintentional injuries rather than disease because of those programs that I've mentioned already. Again, we have technological advances that happened in the later part of the 20th century and into the 21st. And we started having national and international organizations for children's rights. They're no longer a commodity. We had labor laws that were put into effect. So lots of changes happened in the last 100 years in how we feel about women and children, thankfully. So in the 1950s, we saw this resurgence of women saying, wait, my body was made to do this. I believe that my body was made to do this. And this was kind of spearheaded by this book called Thank You, Dr. Lamaze. And Lamaze is an idea, a method of transporting yourself through labor without the use of medications, twilight sleep, that sort of thing. And from the Lamaze method, kind of branched off and became the Bradley method, which is the husband coached. And that's when we started seeing fathers welcomed into the delivery room. There are some other big transitions here. How we treat babies after delivery, that was the LeBoyer method. There's lots of good, rich history in the 1950s about just changing ideas surrounding birth. This is what a delivery room looked like in the 1950s. So we had a lot of work to be done. It still is very medical. This is where the babies went in the 1950s. Everyone got packaged up and put into a nursery, and they were brought out to the moms every 4 hours for feeding. They weren't kept in the rooms with their mothers. And if they, like this little guy over here, he's obviously wanting some attention, but unfortunately he's going to have to wait until that 4-hour mark. They just let them cry it out, which now is just such a barbaric idea when we're caring for newborns. And then we saw what I'm going to call the revolution. So in the 1960s and 70s, lots of things happened regarding women's health. This picture is a picture of Ina May Gaskin and her husband, Stephen Gaskin. This book is her groundbreaking book that came out. So they were starting a commune basically, and they traveled by bus across the country from California to Tennessee. And as that happened, of course, you get men and women together in close quarters, and babies start to come. And she was the attendant. She was the midwife that would help these babies come. So she wrote this book and about her experiences of learning about birth and learning about being around lots of women that are delivering babies. Interestingly enough, the commune is called the Farm. It's still a working commune in Tennessee. You can actually go and visit. I've been there, and they still deliver babies, and they have, I shouldn't say deliver babies. They would be upset with those terms. They catch babies, and they have some of the best outcomes of any other delivery service in the United States, which is amazing. She's written several books since then. Not sure if she's still actually catching babies, but there have been many, many, many midwives that have been trained underneath her. She's what we call a traditional midwife. She didn't have any formal training. She's not a nurse first. And there's even a maneuver that has been coined after her. It's called the Gaskin maneuver that is taught in all medical schools. Just an interesting little side note here. When I was pregnant with my first child, which was many, many decades ago, I went to my local library system, and that was back when they had the Dewey Decimal System. So all the books that were of similar content were on the shelf. And I went to the shelf to try to learn more about childbirth, and this book was there. And I picked up this book. And so this is my first look into the world of childbirth as a young pregnant woman. And I think it probably influenced my entire trajectory for not only the birth of my own 5 children, but also for my career and how I feel about birth in general. Just a little fun fact side note there. In the 1960s, we also saw a lot of the revolution regarding having birth control. So the pill was actually invented and put out in the, I think it was late 50s, early 60s. And it coincided with this, we want to be in control of our bodies. We want to be able to birth our babies. We know our bodies know how to do this. We want to be able to feed our babies, and we want to decide if we want to have babies or not. And then in the 70s, of course, we had even further influence into women's rights as far as childbearing. Here's another iconic picture of Ina May Gaskin again, teaching other midwives at the farm. And she has some really amazing quotes, some really amazing insight. This is her more modern day picture. We're the only species of mammal that doubts our ability to give birth. It's profitable to scare women about birth, but let's stop it. I tell women your body's not a lemon. And she's so true here. If we think about our bodies, obviously our species wouldn't have continued if it didn't know what it was doing. Granted, like I already mentioned, we did have a lot more maternal death and fetal death in our history, but we also had a lot less intervention and still had the ability to continue on our species. So if you're interested in further study or viewing, PBS has an amazing series called Call the Midwife. I highly recommend it. It's in its 10th season. They are historically accurate. It's set in East End London. It looks at a midwifery service a lot like what Frontier Midwifery Service was back in the day. It's set in the 1950s and then goes on through the decades. I think we're up to the mid 60s now, maybe even a little bit later. Anyway, if you get the opportunity, I highly recommend it. And then, of course, anything Ina May Gaskin has written, you can look into The Farm in Tennessee. Penny Simkin, known as the grandmother of all doulas, has written some amazing books. If you're going to be a birth partner in any setting, whether it be nursing, whether it be as a doula, whether it be as a significant other, you want to look at the groundbreaking book, The Birth Partner. It tells you how you can be part of that. And then the Labor Progress Handbook is really a textbook And this was the early idea of the spinning babies method. And spinning babies, it's not on the slide, but I would highly recommend if anyone is going to be doing any sort of birth work, you need to understand the spinning babies um, ideology and the technique and movements that they utilize. It's basically bringing back some of that ancient wisdom that has been lost throughout our generations and bringing it back to the forefront. And then I've also given a video and a reading list in the notes below if you want more information. Okay, so where are we now? Now we are primarily physician-centered. There, in some places of the country, there are more midwives than physicians, but the majority of deliveries in the United States happen with physicians rather than midwives. The majority of the deliveries happen inside hospitals versus home or alternative birthing centers. We have increased technology. We have the increased threat of litigation. If you work in labor and delivery, it's the most litigious uh, specialty. And the one statistic I saw is that if you work there 20 years, you're guaranteed to at least be in a deposition, if not a full-blown lawsuit, at least once in your career. And for most people that I know, that statistic is pretty accurate. We work under time constraints. We want women to get in, have their babies, and then get out. And then we work under economic restraints. We have to make money at this. And a lot of our practices are focused on those goals, unfortunately. So this is just a fun little slide. Evidence-based birth is, the owner is Rebecca Decker, who is a PhD RN, and she does research about birth and has a website and lots of other resources. She's written a couple of books. And so go ahead and check her out. She put this together, and this looks at all the common activities that we utilize in birth today, what their percentages are, and then whether it's supported by the evidence. And everything she uses is supported by actual evidence. We're going to talk more about evidence-based practice in just a few minutes and what doing research actually means. So this is what a modern day hospital delivery room looks like. It is decorated to look like a nice homey environment, but you have medical staff and medical intervention right there at your fingertips. Unfortunately, this is where mom spends most of her time because she is going to be connected to a fetal monitor, which is our window into the baby. And we'll talk more about that in another lecture. This is a home birth situation where a mom might invite the people that she wants to be in her delivery. She's in her own home environment, and she is used to the germs that are in her own home, and she can have the people in attendance that she wants there. Now, a lot of people have the idea that home birth is not safe. And in some circumstances, that's true. You have to be a good candidate for home birth, but home delivery has actually been proven in several studies to be as safe, if not safer, than hospital delivery for both maternal and fetal outcomes. And as always, whenever I give you a piece of information, I'm going to give you some resources. So you could take a look at this article, and it tells you where most of the deliveries are happening and in which states you see a higher percentage of home births. And then these are a couple of articles that talk about the safety of home birth versus hospital birth. So take a look there. And for the students in my live class, we can certainly discuss this. So where do we stand? All of our statistics change. They're fluid. I've taken these, the most current that I can, and we're in the year 2021 right now. So our primary C-section deliveries in the NTSV category, which is considered the lowest risk category. These are women that probably do have the lowest risk of needing a cesarean section. NTSV is a common metric that we utilize. It stands for nulliparous term, spontaneous, singleton, and vertex. And I'll explain all those terms at another time. But we are at a primary cesarean delivery rate in the United States of about 25% for this low risk group of women. The World Health Organization recommends less than 15%. for that population of women. All cesarean deliveries, this includes repeats and those in the high risk group, were about 31%. So what that means is if you're going to have a baby in the United States and you were in the low risk category, 1 out of 4 of those women are going to have a cesarean. And if you are in a higher risk category, you're going to have 1 out of 3 of those women are going to have a cesarean in the United States. About 2% of babies are born outside of the hospital. These numbers fluctuate as we get the census results. As those start to come out, we might see more. We might see an increase in that. About less than 0.5 or less than 1% of all women attend any sort of childbirth preparation courses. That's a local statistic. I know there are places where it is higher. In fact, some midwifery services require that women attend some sort of childbirth education in order for them to be cared for by that practice. About 2/3 of women receive an epidural or a spinal as part of their birthing experience. So let's talk a little bit about the United States versus the rest of the world. So you would think that if the United States is the most expensive childbirth expenses, if we spend the most on childbirth than any other country, we must have better outcomes, right? That's what we would think. So here you see that, and these are from, I think, 2017. So these are about the costs of these deliveries in the United States, and you can see they're almost double all the way down for every other country: Australia, Switzerland, United Kingdom, Netherlands, United Arab Emirates, and South Africa. Well, let's look at our statistics. A couple of terms first. When we're talking about mortality, we're talking about the number of people who've died over a specific period of time. So maternal mortality is looking at the death from any cause during pregnancy or within 42 days of either delivery or termination out of 100,000 deliveries. And our statistics are, we're 46th in the world. So we spend almost double over everyone else in the world on caring for our pregnant women. And our rates were about 46 for our maternal mortality and morbidity. And if you are of African American descent, you are going to have 4 times the rate of mortality and morbidity than anyone else in the country. How is that even possible? Here is a graph to show you what I'm talking about. So this says that we're ranked 47th. We've actually moved up a little. We're 46th. That's current from the CDC as of this week. And so all of these countries do better in caring for their moms and babies than the United States does. So take a look at some of these countries. You are more likely to have better outcomes in Cyprus than you are in the United States of America. You're more likely to have better outcomes in Qatar than you are in the United States. You are more likely to have better outcomes in the Czech Republic than you are in the United States. So it's kind of sobering, especially considering the graph I showed you about how much money we spend. This is a graph that's been going around. Here is where it was taken. This is the source. And you can see over the last 3 decades, every other country in the world, every other country listed here, has had a decrease in maternal mortality, but the United States has had an increase. Just going to let that percolate for a minute. Here is information from the CDC, and you can see per 100,000 deliveries, depending on your ethnicity and race, you are going to have different outcomes. And here are some of the reasons that we see our mortality rate in our pregnant women. And again, this is current information. So looking at the United States as spending the most amount of money on of anywhere in the world and having some of the worst statistics, what's the major difference? What is the big difference between us and everyone else? Well, one of the major differences is all those other countries that are listed in these graphs, I'm going to go back just a bit. All these other countries, their primary provider for care is a midwife, not a physician. So OBGYN is the primary provider for pregnancy care in the United States, with some midwives. And in all of these other countries, the primary provider is midwives first, because pregnancy is looked at differently in the midwife scope versus it is in the medical scope. And that's just one difference. Now, I'm sure there could be a lot of hot debate about this, but that is just one of the major differences. The other difference is a lot of these countries still promote home birth and support women in the low risk categories to have birth outside of hospitals. So interesting study material. This is certainly something that we could go down. I'm really telling you just for some background to understand where we are. Again, these are the reasons that we see, and these change over the years. We have gone from hemorrhage being the #1 reason that women in the United States are still dying after childbirth to other cardiovascular conditions. And a lot of this is related to hypertensive disorders. So we jump in between sepsis, hemorrhage, and hypertensive disorders. I'm going to talk more about evidence here in just a minute. So this is just looking at the differences between who uses midwives and who doesn't, and just a interesting scenario of where we are. And this are the differences between midwifery care and obstetrical care. And I don't want to go down this hole too deeply. I just think that it's important as people that are going to be working in our system and people that are potentially going to be having babies in our system to look at the differences between the basic ideology of midwifery care versus obstetrical care. Now, I'm not saying we don't need obstetricians. We absolutely do. But for the majority of women that are in the low risk categories that meet the criteria, midwifery care is not only acceptable, but superior to what we get from obstetrical care, because these are surgeons first, and we need them to utilize their skills in the things they were trained in the high-risk deliveries, in the high-risk care of these women. They don't necessarily need to be utilized in the low-risk care of women. And I think our outcomes would change and our costs would go down if we would utilize that method. So this is a great podcast, again, evidence-based birth. I've put the actual podcast here. It's on YouTube, and you can look at the evidence behind midwives and the safety behind them. So our Healthy People 2030 goals, these are national goals that we set, think tanks and teams of people get together and set these national goals. And for 2030, we're really emphasizing health promotion and disease prevention. That's what these goals are usually based on. And these are the things that we're focusing on within those 2030 goals. So spend some time in your book looking at the history of these and what it is that we're hoping to focus. Now, each specialty, they kind of break them down into smaller goals. And one of the things that we want to see, of course, is a decrease in maternal death and equity among all ethnicities and races, and a decrease in costs for maternity care. And so you can take a look at those and spend some time getting to know them, because you will hear about them for the next decade. And also our fetal mortality, which is our 20 weeks and older, is not up there. Last time I looked, we were like in the 40, we were 41 in the countries that we were compared to. So we don't do as well there either. And our neonatal mortality rate and infant mortality rates are not fantastic either. So of all the things, all the money that we're spending, all the effort that we're putting in, we're not seeing the outcomes for our moms and our babies. And here's a little graphic about our childhood mortality. And this is kind of interesting. The leading cause of death between children 1 to 14 in our 1 to 4 age, it's unintentional injuries and then congenital malformations. So babies that were born with something that is affecting their health. But then in ages 5 to 14, unintentional injuries is first, and then cancer. People think of childhood cancer as being rare, and it actually is not rare. So that's a whole nother lecture for a whole nother time, but I just wanted to point that out. So some of the things that affect our maternal and child health in the United States are family and genetics. Those are things that we can't necessarily change. And then society. We're going to spend a lot of time talking about society, specifically social media and the information that is spread on social media. And when I say fake news, I am not making a political statement. I am merely using the term to represent something that is not factual. And looking at our culture, we're going to see that definitely plays a part in how we feel about our maternal and child health care, health status and lifestyle, whether you have access to health care, not just whether you can pay for it, but can you get there? Do you have to ride 3 buses and wait for 6 hours with your other 2 children to get maternity care? Because if that's the case, it's not really access. That is almost impossible. And then we have improved diagnostic ability and treatment for a lot of our disease processes. We're making new discoveries and changes all the time. And then empowerment of the healthcare consumer. Is the person receiving healthcare actually empowered to make decisions? Do they speak the language of the person providing care? Are they from the same culture? Those are all things that can play a part. So we can have all of these things can either positively affect our maternal and child health or negatively affect our maternal and child health. And we're going to explore that a little more as we move on. So we have an increased responsibility. We are requiring individuals and families to have an increased responsibility for their own health, because at the end of the day, they are hiring us as care providers to give them advice and help guide their way to better health, but they have to make the decision to follow the advice that we've given or not follow it, to take the medication or intervention that we're recommending or not take it. So at the end of the day, the responsibility lies with the individual. And as we move from a very hierarchical idea in healthcare more to a partnership with our clients and patients, for lack of a better word, then we see that shift in that mentality about it. Family has a right to have information and then participate in that decision-making process. And I think this is one of the things we lack the most in our women's health, is allowing them to actually make a decision once they've been given all the information. And then respecting them, including the rest of the family that's involved in the care, and respecting the decision for them to not follow the advice that we have put forth to them. Other barriers that we see, finances, of course, are going to be a huge barrier. Like I mentioned before, lack of transportation, the inability of the knowledge base. So if you think about all the effort you've put into this point in building your knowledge base in the world of medicine, from terms down to the cellular level, understanding the human body, anatomy, physiology, understanding the chemistry of it, and now learning about medications and how they work in the body, and then learning about communication. Like, you've built so much just to this point to understand this field. When you're talking to your average patient, they don't have that same baseline of knowledge. So we think differently as we build that baseline of knowledge. And so we have to recognize that not everyone is at that same baseline. And the things that we tell people really will be based on trust. Do they trust what we're saying to them? I think we're seeing this in our modern day society, is that there's a huge lack of trust in what we are saying, and because of this big gap in this baseline knowledge, one of the reasons. So nurses have a unique opportunity to intervene in that process and assess for things like socio-cultural barriers and finances and resources and helping them overcome those barriers. Nurses are the most trusted profession and have been, I think we're going on 15, 18 years now. And people look to nurses in their family, they look to nurses in their community, they look to nurses in their socio groups for information. So think about that as you move into this field of nursing, the responsibility that you're taking on by moving into this field. Okay, so now we're going to talk a little bit about culture, and there are going to be some graphic pictures coming up, and it goes along with our discussion here. So when you talk about enculturation, what does this mean? This goes back to a sociology term, and enculturation is how you view the rest of the world based on the cultural norms that you have experienced. So how is this going to influence your surrounding your ideas about birth and babies and child rearing? Well, it actually has a huge effect on how you feel about it, and it affects what you believe. It affects what you intrinsically know, and we have a unique I won't say opportunity, but we have a unique experience right now, is that everyone's culture is blasted all over social media, and it's different than our own many times. And so it influences how we feel about what other people are doing. So for instance, how do you think these women feel about breasts? What do you think in their culture they've learned about breasts? Well, most likely they've learned that breasts are just a natural part of the human body, and they're not to be covered up, and they're there to serve a purpose, to feed babies, and they're not highly sexual, right? How do we in the United States feel about breasts? Well, we use them to sell you just about anything. Here's an example. Here's an example. And what are they actually for? Like, we've sexualized them and used them in our advertisements, but what are they actually on our bodies for? Well, their primary purpose is this: they are to feed human babies. So when I talk about culture, these things all play a big part. Here's another influence. There was just a huge expanse of women wanting to eat their placentas after they saw this social media influence. And if you look at the history of what's called placentaphagy, if you look at the history of it and look at the research, this is what they have found, is that there's a lot of anecdotal evidence. A lot of people have said, I did this and then this happened, which does not mean that they correlate. Correlation does not equal causation, but there's been so much social media outpouring, and you see lots of different influential people in our society, stars and whatnot, putting this anecdotal information out there. And so people think, well, if they're doing it, it must be great. There's been the idea that women throughout history ate their placentas. Untrue. That is not supported by any of our historical documents. There has been the idea that all mammals eat their placenta. Not true. The examples that are being compared to are those that are trying to clean up their nest and keep them keep the smell away from predators. Here's what we know right now today. Now, this might change because science is ever evolving, but what we know right now is that there are no specific benefits for eating your placenta. And I know I'm going to get a lot of feedback from this, but I am ready to support the science and give you what is out there. The only thing that has been put out into the evidence is anecdotal. It cannot be repeated. And so the idea is it decreases depression and increases milk supply. And as we continue on in our lectures, we'll talk about how these things might go together. So like the increase of the estrogen that the placenta is full of might make your mood feel a little bit better. But the reason why we want to decrease that estrogen after delivery is because it increases our chance for forming a clot, and we're already hypercoagulable after delivery. And so we don't want to increase our chances of having a clot. And then increasing milk supply, the physiology doesn't actually work because estrogen is the hormone that depresses prolactin. Prolactin is the hormone that allows our full milk supply to come in. And so there's an inverse relationship. So the more estrogen you have, the less amount of prolactin you have. And so as the estrogen goes down, the prolactin goes up. So it's not physiologically, it doesn't make sense. So I don't want to turn this into a large debate about the benefits of eating your placenta or not. But we do know this. We know that late onset GBS infections have been found in the consumption of capsules containing dehydrated placenta. So much so that Johns Hopkins University and the CDC put out a warning that it is not recommended to eat your own placenta, regardless of what the people that are preparing them and selling them to you tell you. And there's information in the notes if you want to spend some more time. My point of this conversation is to look at how our society influences how we feel about things. So here's another example. When we developed the vaccine for polio and measles, mumps and rubella and pertussis, it was life-changing. My grandparents lived in a time where they were afraid to send their children outside because of polio. And then once that vaccine was developed, we essentially eliminated these diseases from childhood, which is an amazing feat. You probably know people today, possibly, that were affected by polio. These are our grandparents and great-grandparents, and we are losing them at this time because of their age. But once we eliminated these diseases from circulation within our population of our children and developed herd immunity, we didn't see them anymore. Amazing feat. And the way it was presented in the media contributed to the success of these programs, which, by the way, all of these programs were made mandatory. Not even going to hit that hot topic button right now, but they were all made mandatory. And then there was some information that came about in the late 90s, and it was based on this very small study done by Andrew Wakefield, who is was a doctor in the UK, I believe. And he used this sample of 12 people and related vaccine injury and autism to the MMR vaccine. Well, come to find out, he actually was working for the vaccine injury lawyers when he produced this information. And then as they further researched into this, and it was published in the Lancet, which is a peer-reviewed journal, once they looked into it a little bit further, they found that he actually faked his evidence. It wasn't real. But that small study and the information from that small experience has influenced an entire 2 generations of people now. 2 generations of people. They still believe. If I were to ask you right now, how many people believe that vaccines cause autism or there's a relationship between them, I bet somebody would raise their hand. And it is from this information. So you can see that that influence has definitely affected what's gone on in our society. So here's the dangers of that and the dangers of fake information, fake news. We've seen a resurgence of measles. Measles have come back because we no longer have herd immunity in some pockets, some areas, because people are afraid of the vaccines because they think that there's a vaccine injury relationship, and they are afraid to give them to their children. And so the diseases are just waiting for this opportunity, and they've come back in huge pockets. We also see pertussis, which is whooping cough. I personally have been affected by this. I am vaccinated against pertussis, but still got it. I think it was 2013, and was very ill along with many of my coworkers that spent many weeks off of work because we've seen a resurgence of this. Now, these are all diseases that our newborns and young children cannot be vaccinated against. They can't get these vaccines until they're in the 15-month age frame. And so this is the result of what it looks like when a baby is on a ventilator because it has pertussis. So there are real consequences for this behavior, unfortunately. And this baby wasn't able to be vaccinated. So this baby was relying on herd immunity to keep those diseases at bay. So when we're talking about evidence, if somebody is saying, I did my research, what they're really saying is, I read the result of other people's research. If you're going to actually do research, you're going to dig into you're going to come up with a hypothesis, and then you're going to design a study. And then once you have used one of the 5 methods of doing a research study, then you're going to apply a statistical formula to determine if the results are statistically significant or not. And if they are statistically significant, was it the study that caused the results, or did it just happen by chance? So there's a lot of, and then you're going to let your peers look at all of this data and decide, yes, this appears to be evidence-based, or no, this doesn't appear to be evidence-based. So there's a lot of steps to actually doing your research. So if you hear somebody say, I'm doing my research, it's not really what they mean, usually, unless it actually is a researcher that's talking about it. So the internet makes information available to anyone. It also allows anyone to put information up. And a lot of times what you see on the internet is people taking someone else's research and what we call cherry picking the information, the data that comes from that research to match their agenda. So when we're talking about evidence-based care, we are providing care based on actual research that has been proven to cause this outcome or prevent this outcome. And as nurses, we utilize evidence-based care in our practices. And if you're a nurse for 10 or 20 or 30 years, you're going to see things change. The way you did things 30 years ago is not how you'll be doing them now, because we've had more research and had more evidence that proves that either that is a good idea or that isn't a good idea. So whenever you're reading something, I'm going to implore you, both my live students and my online students, I'm going to implore you, apply the crack test to everything you read. Try to determine these things. Is it current? Is it based on current information? How recently was it updated and edited? We really say anything within the last 3 to 5 years is appropriate and can be considered current. Is it reliable? Does other research support it? Does the author provide references to that research? Is there even an author? Many times you'll see things on the internet where people try to remain anonymous. If there are links, do they actually work? Click on them, put them in the search bar. Who is that author? What are their credentials? A lot of times people are paid by the word to write blog posts, and a lot of times they are supported by specific political agendas to write these posts and put this information out. Who's the publisher? Is there contact information for that author? Are there advertisements on that website? And then here's the most important part, purpose. What is the purpose of this information? Are they trying to convince you of something? Is there evidence, bias? Is there a fact, or is it opinion-based? And who's the intended audience? If you apply this to everything you read, I think you will start to see things with a more discerning eye and try to see what it is. If someone is putting a YouTube video up and also trying to sell supplements, then you can guess they want to get as many clicks and as many views as possible. The more people that view that, the more people that click on that information, the more they're advertising their specific supplement. That's just an example. Okay, we're going to kind of change gears a little bit and move into our caring for women. This is our chapter 2. A couple of things in here that are super important that you will want to know. We want to look at the difference between preventative care, secondary care, and tertiary care. So preventative care is really helping people to prevent the disease or condition before it occurs. What is the number one preventative care technique that any nurse or anyone in healthcare can do? If you said wash your hands, you are correct. Washing our hands helps decrease the amount of bacteria on our hands and decrease the amount of spread to ourselves, to our patients, and between patients. So always, always, always think wash your hands, wash your hands, wash your hands. And it seems so simple. But remember when I was talking earlier about the amount of women that were dying in childbirth, and that was increased in the physician group and decreased in the midwife group because the midwives were washing their hands. They knew this even before they understood germ theory. It's just what you did. So prevention, this is our primary focus in our education, is prevent, prevent, prevent. And then as we move in to secondary prevention, we're going to be looking at early detection and early treatment of adverse health conditions. Health screenings, this is why we go and get mammograms. This is why we go and have pap smears. This is secondary prevention, trying to prevent the spread of that disease. And then tertiary prevention is really the reduction or limitation of the permanent irreversible disease or disability. So now this is tertiary, for the most part, is what we see in our hospitals. And as nurses, we are definitely involved in this type of care. That's what we're performing at the bedside, is tertiary prevention. But we also have to think about secondary and primary when we're caring for these patients. We have to tell them, how do we prevent this from happening again? And how do we take care of it in the early phases? So that's really what our role of a nurse is. One of our roles. We have many roles. The other thing you're going to see in childbearing specifically, when you're dealing with women and children, is complementary and alternative medicine. There's going to be lots of ideas that are out there. And what is our role in complementary and alternative medicine? Well, we often see these two things joined together. Meditation, for instance, or self-hypnosis is used quite often in childbirth. Is that going to hurt anybody? Absolutely not. And are we going to interfere with that if somebody wants to use it? Absolutely not. But if somebody's taking herbs and they're also taking traditional medication, and those two things are conflicted, then it's our responsibility to give that information to the patient. And again, let the patient make the decision what they're going to do. So just know that if you've not been exposed to alternative medicine or complementary alternative medicine before, you will see it in the childbirth realm. When we're talking about communication with our patients, again, we are here to give information, to provide education, and to support. That is our role. So one of the things that we want to convey is empathy and respect and trust that this woman knows what's best for her. Now, there are some circumstances where that can be difficult if there's some self-harm involved, but for the most part, women know what they need, and especially in the realm of childbirth, and we need to respect and support that. We also have a responsibility for confidentiality and privacy. So there's some privacy questions that we ask all pregnant women that need to be done in a private scenario. Those questions are, how many times have you been pregnant? Have you had any miscarriages, abortions, or adoptions? Any sexually transmitted diseases? Are you currently taking any street drugs, alcohol, smoking during pregnancy? Are you involved in any sort of domestic violence? And do you have any mental disability, not disabilities, mental diagnoses that you're dealing with, or have you in the past? So you can see how all of those questions are very private. And I know oftentimes partners think they know everything there is to know about their partner, but that is not always true. And we want to respect the confidentiality and privacy of that patient. So we ask these questions privately. Now, the answers to these questions are sometimes included in our report to the next nurse. We have to be very savvy about making sure that we don't give information that a patient doesn't want us to pass on to anyone else that might be hearing bedside report. So for instance, if she's been pregnant before, but nobody else knows that, we have to be cool when we're passing that information to our next nurse. If she's had a breast augmentation and nobody else knows that, we want to make sure that we are respecting that privacy. If she has a sexually transmitted infection, we cannot share that information with her partner. It has to be up to her to share that. So again, we have to keep that information quiet. And then I want to mention here about body language. I find that pregnant women and birthing women are very astute observers, and they recognize when we're saying one thing, but our body language is saying something else. They pick up on that body language very well. So if we're saying, yeah, and she has a birth plan, but you can see us kind of rolling our eyes and having our own opinions about that, she's going to know how you really feel about it. So making sure that we're watching our body language, super important. When we're looking at our client and family education, remember what I said before is that not everyone has the same baseline. So we need to know, what do they know? And is their culture going to influence what they know? What is their health literacy? Before we can educate them on what they need to know. I'm not going to walk up to a nurse who is also my patient and explain the anatomy and physiology of something in very simple terms. I know that she already has that as a baseline. So I'm going to jump ahead and give her the information that she needs to know. But I'm not going to expect the average person to understand the workings of her anatomy if she hasn't studied it to a deeper level. So making sure that everybody's on the same page is very important. And one of the ways we do this is we are working with a group of people. We call this collaborative care. So we might have case management involved in the care of our patient. We might have social services. We might have a chaplain or a chaplain of their, a clergy of their choice. And labor and delivery, postpartum, and neonatal intensive care nurses work collaboratively. We are on the same team, caring for the same patient in different aspects of her experience. And a lot of times it feels like we are not on the same team. It can feel that way. And we need to remember that we are all involved in this patient's care. So when we're looking at the education of our patient, we want to slow down, repeat whatever needs to be repeated. Remember, most of the time we're talking to people that are either in pain or have experienced some sort of traumatic event or life-changing event. And sometimes hearing, well, the things they hear are not what we're trying to portray. So we need to simplify it and bring it down to what they can hear at that moment. Just like with students, there's nice to know information and there's need to know information. Let's get the need to know information first to that patient, and then we can work on the nice to know or give them some resources so when they're ready to hear the nice to know, they'll be able to do that. So using pictures, illustrations, video, color coding, all of those things can be helpful. We want to chunk information. So for instance, when I get a mom up to the bathroom the first time after she's delivered a baby, I'm going to chunk some information about how to care for herself and the signs and symptoms she's going to be looking for. And she's really open to that at that moment because that's what she's hearing. She's not going to want to talk about something completely unrelated because you can't take in tons of information. They only hear approximately about 10% of what we're saying anyway. And we never want to talk down to a client. We're partners with them. None of us were born knowing the things that we know. These are all based on experience and based on education and based on building that literacy. Again, we're going to evaluate how well that patient understood that information. And the best way, one of the best ways, is either for them to demonstrate what you were talking about. So for instance, you're talking about feeding a baby, demonstrate feeding a baby or changing a diaper, or repeating information back. Okay, I'm going to call the doctor if the baby's not feeding or has less than 6 wet diapers in 24 hours. So those are the kinds of things that we want to hear to make sure that they understand the information. And then, of course, we need to document it. We need to document what it is that we told the patient, how they took the information in, and if they were able to demonstrate or repeat back the information that we gave them. So when we are looking at our community-based nursing care for our women and children, there's lots of touch points that we have to interact with these moms. Prenatal care, super important for us to be building trust. We're going to talk about it in the next lecture about prenatal care and what it is that we're really hoping to accomplish. There's lots of places for women to give birth to their babies. Labor and birth can include hospital, birth center, or home. And we need to be respectful of that. I could get on a whole soapbox right now about how we are not supporting the women that are giving birth in their homes by not appropriately accepting those transfers. But when a very wise physician that I worked with for many years, she's retired now, but we had a home birth transfer, and a lot of the nurses were kind of, you know, grousing around saying, oh, well, train wreck coming in, yada, 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 if she hadn't made that decision. And the physician stopped everybody and said, we are serving the same patient. She's coming to us because she needs help, and we are here to help her. That's our job. And she kind of put a stop to all the grumbling that was going on. And I had a tremendous amount of respect for her after doing that. Again, advantages and disadvantages to some of these out-of-hospital delivery options. If you're going into nursing, most likely you're going to be involved in in-hospital births or possibly birth center births. But know that these are options. And up until about 100 years ago, it was the norm. And looking at how we're going to care for our postpartum women, when they leave the hospital at about 24 hours, which isn't a lot of time, they still need support and care. It truly does take a village to raise our next generation of people. So hopefully there's some sort of telephone consultation opportunities. I know in our local community, we have something called a warm line, and we have breastfeeding support on through the phone. There are some national places where you can get some support, some postpartum depression opportunities to discuss that nationally, but know your local community, know where people get support. They sometimes have outpatient clinics where women can come and talk about feeding their babies, or there's mom groups where women get together and there's some sort of a facilitator that will help run those groups. Sometimes there is high-risk newborn home care or home visit, nurse family partnership type programs. So know what is available in your community, because all of these resources are important. Again, the United States kind of falls behind here. In other places, there are standardized amounts of visits, home visits, that every woman gets, and long-term support in the postpartum arena. And sometimes you'll see for women's health care that there will be some other women's health specific places, like maybe they can go and get their birth control care or their menopause care. Retail centers end up being a huge, filling this gap where sometimes they offer courses, classes, while also trying to support themselves by selling retail items. And we do have some of those here in our local area as well. So again, our role is anticipatory guidance, helping them know what to expect, education, and providing resources. Our role is not to judge and not to try to influence them with our own ideas. Our ideas are ours and our opinion. And in childbearing specifically, we should never talk about what our experiences were, because they were unique to us and to our knowledge base and to our culture and to our specific situation. A couple of legal and ethical issues that surround maternal and child health. There's abortion. And this can be a hot topic for a lot of nurses. You as a nurse do have the right to say, I have a personal belief against this specific practice and can choose to have your assignment changed, but you must report that. We report it as in you have to tell your supervisor and let them know so that they can make arrangements for this person to have care. And substance abuse, there's a big hot topic there. Fetal injury while women are pregnant, different areas deal with this differently. Different areas deal with the result of substance abuse on the baby once the baby's born. And that's a whole nother topic, but just know that that's one of the ethical issues that we deal with. There's all kinds of intrauterine therapy that are available to women, especially in the larger metropolitan areas. And we always have to balance everything with the maternal fetal conflict. Does the benefit to the mom outweigh the negative to the fetus, and so on and so forth. So if you're going to talk about beneficence and autonomy, these can be very complex issues. And in labor and delivery, again, in serving women in this time period, you're going to see lots of culture come out, lots of their own personal societal views come out, and lots of your own emotions as a nurse. These are very complicated situations, and hopefully you don't have to deal with them on your own. You'll have that team of people to support you. We have stem cell research. We have umbilical cord banking, the public versus private. So some places you have the opportunity to save this umbilical cord publicly, or those that have the means can put them in private banks. There is all kinds of gene therapy going on with CRISPR, which was discovered in the last decade. I think it's going to change the future of childbearing and embryonics. And again, this is beyond the scope of this course. I'm just giving you a little snapshot into some of the conversations and talk that are happening, discovered by Jennifer Doudna, by the way. Other things are informed consent and age of majority. Normally that's 18 years, but there are certain responsibilities, certain situations that make them emancipated. Talking about informed consent, this is a common myth that it's the nurse's responsibility to get informed consent, and actually it's just the nurse's responsibility to get a signature on the informed consent form. It is the provider's responsibility to actually obtain informed consent. And the way you obtain informed consent is to offer benefits, to offer alternatives, and to offer the negatives of whatever is being suggested. So informed consent includes benefits, it includes negatives, and it includes alternatives. And here are some of those exceptions to parental consent. So a mature minor in some circumstances can give parental consent, or an emancipated minor, including pregnancy, allows them to be emancipated. So then they can make their own informed consent. And refusal. All clients have the right to refuse medical treatment. Where it sometimes gets a little bit sticky is when they're refusing medical treatment for a young child. And sometimes those specific cases end up going to court to determine if this is truly in the child's best interest or not. Again, something that can be discussed outside of this lecture. Confidentiality. We have standards for confidentiality, like I mentioned before, making sure that we're not passing on information that patients don't want passed on. The only exception is that we are mandatory reporters for abuse, injuries due to weapons or criminal acts, threats to self. There are specific diseases that we have to inform the health department about, or a threat to an identifiable person. Now, I've had a lot of talk in this lecture about a lot of different things. And I love this quote: the best teachers are those who show you where to look, but they do not tell you what to see. So a lot of opinions are probably going to come up about this lecture, and all are valid, all are open. And I welcome all of them. Having intelligent conversations with educated people is one of my favorite pastimes. If you want to know what it is that you need to know out of this lecture, again, this was just kind of a historical lesson, where we've been, where we are now. But these are the objectives that my students need to focus on. These are the things that we needed to learn from this lecture. So if you're able to answer all of these objectives, or at least know where to go for that information, then you have met the requirements of this lecture, and you're ready to continue on. Thanks so much for joining me. And if you have questions, you can look down for my contact information below. If those are my online students, if you have comments or want to have a discussion in the comments, I welcome that. Thanks so much.